All right, guys, so the revised PALS cheat sheet. I went through and corrected the less than and greater than arrows in the wrong places and things like that, and I'm reposting. Let's get down to it. First things first, stop whining. This is only going to be as hard as you let it be. If you go in prepared, it's going to look like you're prepared. You're going to perform like you were prepared. The next thing is you need to read the book. You need to purchase a copy and read the PALS book before you walk into the classroom. Go ahead and lay a foundation for that knowledge. Don't borrow a book. Don't use a book sitting on the desk just so it meets AHA guidelines. Buy the book, read the book. Now, kids are not small adults, not on hardly any level, okay? On many levels, the pediatric body works completely differently, all right? Only a few of those differences are going to be highlighted in PALS. So take that with you when you go out into your career and you're actually working on kids. Take the time to remember a few of the differences that are highlighted in PALS because they are probably either the most important or the ones that are most frequently done incorrectly out in the field, right? Because PALS is research-based. It is evidence-based. Let's discuss a couple of those differences. The first one's going to be airway. Airway is one of your new most important things when it comes to pediatrics. I know it was put on the back burner in ACLS. You could intubate later on in the scenario. That was because a lot of people were abandoning compressions to perform an intubation. With children, you need a patent airway. Now, that doesn't mean you intubate right off the bat. It means that you ensure a patent airway when you're working on a child. Many of the root causes of the most detrimental cases in pediatrics are going to be airway or fluid related, and we'll talk more about fluid in a minute. So in terms of airway, the narrowest portion of the pediatric airway is at the level of the cricoid cartilage, right? It's not the vocal cords. It's at the level of the cricoid cartilage. Remember that. In the adult airway, the narrowest portion is what you can see, okay? Which is why we put a balloon just past it and then inflate it so it can't come back out. When you're intubating an adult patient, a quick glance at the vocal cords tells you if your tube is going to fit or not. This is not always the case in peds because below the vocal cords, there is a section which you cannot see. That is the reason we have a formula for calculating tube size because you have no real way to know the exact size of that airway. An old school trick, something you can just remember for later, is to look at the size of the child's pinky. And very often that will be very close to an applicable tube size. Now, you're not going to have a box you can check on an ACLS exam for that, right? You're not going to be able to say, oh, I just used the pinky. You need to remember the formula. You need to use the formula and commit it to memory. The bottom part's just a trick. All right, to cuff or not to cuff? This is a question I get asked a lot. Why don't we use cuff tubes in peds more often? So remember what I said about in children, the cuff tubes are not always necessary in the emergency setting due to that, okay? We can't really tell what the most narrow portion is, so we use our formula, which usually comes out to be correct enough that the tube fits rather well inside the trachea, and there's no need to have a cuffed tube, all right? Cuff tubes do have their use, but often enough the risk of tracheal necrosis outweighs that in the emergency setting. Now, if you're a pediatrician watching this, you know why and when you would use a cuffed tube. But I think we can all kind of agree that there is not really a reason to have a ton of cuff tubes on ambulances when we talk about pediatric cardiac arrest and pediatric trauma, because it is often enough that cuff can get misused, it can get overinflated, tracheal necrosis can be a real problem. All right, so another pearl to remember. The cause of pediatric bradycardia is always hypoxia until proven otherwise. And the reason I say that is it is the most common cause of bradycardia in pediatrics. Hypoxia will cause your child to become bradycardic. Children respond horribly to poor airway management. So you need to make sure you have a patent airway and you need to make sure you have good oxygenation because it will result in cardiac arrest, respiratory failure, etc. Okay? So let's talk about compressions really quickly. This is another important part of PALS. Regardless of the rhythm on that monitor, any pediatric patient with a pulse below 60 gets chest compressions. The reason is that heart rate of 60 is not enough to perfuse the pediatric patient. Now, I'm not talking about a 17-year-old. Please bear that in mind. When we talk about small children, if you have a baby with a heart rate of 59, that's not enough. It needs chest compressions in order to maintain any semblance of something that is not cardiac arrest. It's just like a car. It can sputter out. The cool thing here is that your compressions are done at the normal rate they're done for everyone else, 100 to 120 compressions a minute. That's as fast as you can circulate blood manually from the outside. The next pearl I want to talk about is atropine. So in ACLS, you are allowed to be all willy-nilly with atropine. Hopefully, if you're out in the field now, you know that that's not the way it usually works in the real world. But in ACLS, you could try atropine on a third-degree heart block, and there wasn't really a penalty for that because that's how ACLS is written, okay? Not the case in PALS. You can't just go willy-nilly with atropine in PALS. It can cause paradoxic bradycardia. That is a real problem in children. When you have a chemically induced bradycardia, it is hard to treat. And then you're doing what I call making soup. You're adding other interventions on top of that atropine to try to undo the atropine, and that usually ends up poorly. So remember, epinephrine is your friend. Open your PALS book and go through all of the indications for epinephrine, and you will be very surprised. Epi is used a lot in children because it's effective, all right? It has a lot of alpha effects. This is one of the things that children rely on to raise blood pressure. We'll talk about that more here in just a second. But remember epi. Epi's indicated a lot in PALS. Another thing here concerning epi is that you need to remember that when you give epi through the ET tube, which you shouldn't be doing anymore, let's be frank about that one. You should have an IV, you should have an IO. We have access now. But if you do give ET tube epi, 1 to 1,000 is indicated in this point. It's very simple reasoning behind it. Kids don't have giant lung volumes. It's not like slamming IV 1 to 1 epinephrine. It's going to diffuse through the membranes more slowly. 1 to 1 is indicated. This particular tip comes with the caveat that you should check your book every time you get one for this because they may update it in, they may update it out. Check your book, be 100% sure about this, and be ready to stand on that. There are enough PALS instructors out there who either disagree with it or don't know it, so make sure you know that. Vital signs. Commit as much about vital signs to memory as possible. Pediatric patients get their own vital signs because it is important. There are a couple of general rules, though, that you can remember. One of them is on hypotension. So hypotension. Neonates should have a blood pressure of about 60 millimeters of mercury systolic. Anything below that is usually considered hypotension, all right? So your minimum should be 60. Infants through 10 years old, anything below 70 is considered hypotension. So a systolic of 70, a systolic below 70 is considered hypotension. And then in children greater than 10 years old, they should have a 90 systolic or better, all right? They kind of approach the adult realm of things. The other thing is in bradycardia. In neonates, they are considered bradycardic below 80 beats a minute. Now, that doesn't mean you start compressions at 80 beats a minute. Compressions is still set at 60 across the board. But in neonates, they are below 80. They are considered bradycardic. In infants through 10 years old, any heart rate below 75 is considered bradycardic. And remember, all this has to be symptomatic. This is not like a simple number and treat. You treat the patient, not the monitor. In children through 10 years old, it should be a heart rate above 60. So they should have a pulse rate above 60. Okay, and then that kind of ties into the regular guidelines. Now, this does not reflect every PALS course, just so you know. There's a little caveat at the bottom. These numbers are from the U.S. Government Department of Health and Human Services, and that is a pretty credible source. There are several PALS courses out there, though the vast majority of you will take the AHA. Just remember that PALS is not a copyrighted term, and a lot of people have come up with their own courses, and you may be in one of those. So respiratory rates. Respiratory rates get their own slide because they're that important. Remember, chief cause of bradycardia in kids is always hypoxia. So with infants, they are bradypneic at a rate of less than 30. With toddlers, less than 24. Preschoolers, less than 22. School age, less than 18 breaths a minute. And an adolescent goes up to the adult realm of things. They are bradypneic below 12. Now, Glasgow Coma Scale. Glasgow Coma Scale is a very broad indicator of things, but it is a general summary that's very good. One thing you need to remember in the PALS course is less than 8, intubate. It's a nice little rhyme. Any GCS below 7, or any GCS of 7 and below, indicates that a child cannot protect their own airway. Now, this is an acute reduction in GCS. There are children who have a GCS below that who have long-standing diseases or other things, but a child who was playing and then got hit by a car, so they were GCS 15 and now they have a GCS of 7, that's a strong indication they can't protect their own airway, and you may need to put in an adjunct to prevent aspiration in children. Now, pediatric sepsis. which is a common problem, so much so you'll hear about it in PALS. Children tolerate fluids very, very well. They tolerate them much better than the 80-year-old CHF patient that you're probably more used to dealing with. In pediatric sepsis, consider the level of dehydration a child can achieve is often worse than that of adult. They can compensate longer. We've all heard those old adages about how children will compensate, and then die. So use fluid boluses for hypotension and consider greater amounts of fluid per kilo than you would for an adult before moving to pressor agents. Now, what does that mean? It means 20 ml per kilo fluid boluses like you've been taught since the beginning, but you can repeat them more than you could in an adult before you move to a pressor agent. So in the particular place I work, as well as every county that touches it and every county that touches them, rather than 2 fluid boluses and then a pressor agent like we do in adults, we would do 4 fluid boluses and then move to a pressor agent in a ped. Pressor agents don't work as well in peds, and the reason is inotropy. So pediatric patients don't have the ability to adjust inotropy the way we do. They don't have the cardiac musculature or innervation to adapt the way that we do. That's why they compensate, and then die, right? It's not easily improved even with drugs, because even with drugs, you're not really, you don't have a ton of muscle to influence. It's like having a 4-cylinder engine in a dump truck, right? You can hop it up, you can make the engine run harder, but in the end, there's no substitute for displacement. There's no substitute for musculature in the human heart. Peds often improve their perfusion by increasing their heart rate and vasoconstriction, okay? This is one reason that pediatric capillary refill is so important. So vasoconstriction is a big deal, and they cannot, or adults cannot vasoconstrict with the same tenacity that a child can. So their compensatory mechanisms are different. Don't expect too much from your dopamine drip or your norepinephrine drip in pediatrics. It's not always going to have that wild turnaround that you get with an adult, okay, that you sometimes get with an adult. So a couple of the pearls, things you need to remember. The tongue is always going to be the most common airway obstruction in adults and peds, okay? Suspect choking in any audible stridor without a pathologic cause, so not an anaphylaxis. They're probably not choking during anaphylaxis, but no pathology, but you hear stridor, look for the airway obstruction. There might be one there. Remember, pacing is still an option. We turn the meds too quickly in children and start creating that soup I was talking about. Know your vital signs, know your meds, and know your dosages. When you go through your scenarios, your evaluator is not going to provide you with that information. Know where your Broslow tape is as well. I'm not the world's biggest fan of the Broslow tape because I think it encourages people to get a little lax on their practice, but know where it is and be able to use it. When you don't know, find out. Also remember that oxygenation fixes most things. Try that first. When you have a dyspneic patient, apply oxygen. It always helps if that's the root cause, okay? Now, with that said, that's it. That is the revised PALS cheat sheet, and I hope you guys enjoyed it, and I hope you find it useful. Thanks for watching.